Sepsis is a life-threatening condition caused by a dysregulated host response to infection, leading to organ dysfunction. Septic shock is a severe subset with profound circulatory and metabolic abnormalities associated with high mortality. The modern definition emphasizes host response imbalance rather than infection alone. Sepsis is diagnosed when infection is associated with an increase in sequential organ failure assessment score of at least 2 points. Septic shock requires vasopressors to maintain mean arterial pressure of at least 65 millimeters of mercury with lactate above 2 millimoles per liter despite fluids. Common infection sources include pneumonia, intra-abdominal infections, and genitourinary infections. Gram-positive organisms such as Staphylococcus aureus and gram-negative organisms such as Escherichia coli are frequent pathogens. Fungal infections account for a significant proportion of intensive care unit sepsis cases. Globally, sepsis affects tens of millions annually and contributes to nearly 1/5 of all deaths. Pathogenesis begins with pathogen-associated and damage-associated molecular patterns activating immune receptors. This triggers cytokine release including tumor necrosis factor and interleukin-1 causing systemic inflammation. Endothelial activation leads to vasodilation, capillary leak, and microvascular thrombosis. Coagulation pathways are activated with fibrin deposition and impaired anticoagulant mechanisms. Mitochondrial dysfunction and impaired oxygen utilization lead to elevated lactate levels. Immune suppression follows with lymphocyte apoptosis and increased susceptibility to secondary infections. Clinical approach begins by asking if infection and organ dysfunction are present. Organ dysfunction is assessed using the sequential organ failure assessment score across 6 systems. Quick screening uses systolic blood pressure below 100 millimeters of mercury, respiratory rate above 22, and altered mentation. Cardiorespiratory manifestations include acute respiratory distress syndrome with hypoxemia and bilateral infiltrates. Renal dysfunction is common with acute kidney injury and reduced urine output. Neurologic manifestations include delirium, coma, and long-term cognitive impairment. Laboratory findings include leukocytosis or leukopenia, metabolic acidosis, and elevated lactate levels. Early recognition and rapid treatment are critical to reduce mortality. The Hour 1 bundle includes measuring lactate and obtaining blood cultures before antibiotics. Broad-spectrum intravenous antibiotics must be started within 1 hour. Fluid resuscitation with 30 milliliters per kilogram crystalloids is given for hypotension or high lactate. Vasopressors such as norepinephrine are used if hypotension persists to maintain perfusion. Blood transfusion is reserved for hemoglobin less than or equal to 7 grams per deciliter. Mechanical ventilation is used for respiratory failure with lung protective strategies. Glucocorticoids such as hydrocortisone are used only if shock persists despite fluids and vasopressors. Monitoring includes lactate trends, urine output, and organ perfusion assessment. Antibiotic therapy should be de-escalated based on culture results and clinical response. Supportive care includes glucose control, thromboprophylaxis, and minimal sedation. Despite advances, mortality remains around 20%, with significant long-term disability in survivors. Early recognition, rapid resuscitation, and targeted therapy are the cornerstone of sepsis and septic shock management.